I'm Dr. Nancy Epstein and a professor of clinical neurosurgery at the School of Medicine, State University of New York at Stony Brook. I'm also editor-in-chief of Surgical Neurology International. Today I'm going to be discussing the treatment options for cranial meningiomas, and I'm going to focus on first, what do you do in the stable asymptomatic patients? These are patients where surgery is really not needed because they don't have evidence of significant tumor growth or edema and shift. Here you can see a left sphenoid wing meningioma on this T1 enhanced MR, where you have a left sphenoid wing or temporal base tumor without shift or edema warranting operative intervention. There are also surgical options, however, for symptomatic patients with cranial meningiomas, and here you can see an enhanced MRI scan. It's involving the left temporoparietal region, and the green arrows are showing you basically are pointing to the peritumoral edema associated with this lesion. Surgical options may include stereotactic radiosurgery or open surgical intervention. The locations of asymptomatic and symptomatic meningiomas can vary: frontal, parietal, occipital, as well as temporal. And here on the sagittal figurative diagram, you can see parasagittal lesions, the olfactory groove lesions, those in the suprasellar regions, and also those in the cerebellar or posterior fossa areas. The locations of the asymptomatic and symptomatic meningiomas can be above or below the tentorium, and here the tentorium is illustrated with the supratentorial compartment above, the infratentorial compartment below. In addition to that, you have in the posterior fossa, you've got tumors that may involve the clivus or indeed the foramen magnum. Literature for managing asymptomatic meningiomas includes Olivero's study in JNS in 1995. The study included 57 asymptomatic patients followed over a 32-month period. The range was between 6 to 15 years. 25 of these 57 were convexity lesions, as illustrated here. And you can see on this left parasagittal convexity meningioma image on this T1 weighted contrast enhanced MR, a parasagittal lesion that may indeed be invading the sinus. No patient became symptomatic in this series. The 57 cases were rescanned every 3 months for the first year, then every year for a few years, then every other year. Here's an example of such a right frontal meningioma that would remain asymptomatic. In that series, a T1 enhanced study seen in here. That's a parasagittal image. Here on an axial T1 unenhanced study, you can see the tumor without associated edema, and here's a T1 enhanced MR, again, axial study showing you the right frontal lesion. 35 of 57 patients in this series showed no growth of the tumor over an average of 29 months. The range was 3 to 72 months. And here is an example of an incidental right cerebellar tumor. Again, there is no edema associated with this lesion. Here is an example of a right parasagittal posterior frontal tumor dash parietal lesion that shows no edema, but it's just incidentally located. In 10 cases, tumor grew, but patients had no symptoms. It grew an average of 2.4 millimeters a year over an average of 47 months. The range was between 6 months and 15 years. And here's an example of such a left convexity meningioma, again without edema or shift, or in this example, a right sphenoid wing meningioma. They concluded that for these 57 asymptomatic patients who did not require surgery, they stated, quote, the vast majority showed minimal to no growth over periods of time measured in years. And again, example of a left temporal fossa incidental meningioma seen on a T1 enhanced axial MR, and a right parietal meningioma, again incidental, located here on a T2 coronal study. Let's look at stereotactic radiosurgery for cranial meningiomas. Cyberknife radiosurgery for 199 meningiomas was reported by Colombo in neurosurgery in 2009. 114 of these patients had had prior surgery. They were benign lesions, and here's an example of a right convexity parasagittal meningioma. Here on the axial MR studies, you see on the T1 image the lesion, on the T2 image, and on the T1 enhanced axial MRI scan, the lesion is circled. On the sagittal as well as coronal studies, here is a T2 parasagittal image, T1 parasagittal image that's enhanced with gadolinium, and here's your coronal enhanced study. The location for these 199 tumors, posterior fossa, convexity, falx and tentorium, and optic nerve, these were the largest groups. And here's an example of a massive cellular and supracellular meningioma potentially compressing the optic nerve apparatus. Seen here on the sagittal image and here on your coronal image. Symptomatic candidates for cyberknife radiosurgery in this series. Why were they candidates? Lesions were growing, there was residual tumor. Patients were unsuitable for surgery, particularly in view of the location of the tumor, and thus this made them candidates for cyberknife radiosurgery. Here's an example of a right posterior frontal tumor seen on the T1 enhanced study, and here you can see with the arrow the shift associated with that. Here below it, the T2 axial MR, again the lesion is shown, and the peritumoral edema is more readily visualized. Symptomatic candidates for cyberknife radiosurgery, as in this example, showing multiple cranial meningiomas involving the left frontotemporal, the left occipital, as well as the parasagittal locations of tumors. The cyberknife plan for these parasagittal tumors can be illustrated here. Tumor volume for symptomatic candidates for cyberknife radiosurgery. The mean tumor volume in this series was 7.5 mLs. The range 0.1 to 64 mLs, followed an average of 30 months, and the range was 1 to 59 months, so nearly a 5-year duration. Here's an example of a cellular lesion that might have been treated with cyberknife radiosurgery. Cyberknife radiosurgery planning for symptomatic meningiomas. Here's a good example of a left paracellular lesion and the stereotactic plan. Here, clearly, they're avoiding the brainstem. Here is the nidus of tumor, and you want to deliver a larger dose to the tumor itself, avoiding the more critical structures. Cyberknife doses and residual tumor volume for these 199 lesions. 12 to 25 gray were administered for an average of 18.5. Residual tumor volume, less than 36 cc's, equal to 148 cc's, and more 7 cc's. Those were the criteria that were used. And here is a cellular and supracellular lesion. Here you're on your coronal image, and here on your parasagittal studies. What were the outcomes for cyberknife radiosurgery in these 199 tumors? 154 patients remained stable, 30 were better, 7 were worse, and 3 required repeat stereotactic radiosurgery, while 4 were then switched to requiring open surgical intervention. And here's an example of a massive right skull-based lesion that may well have been a recurrent lesion because of difficulty fully resecting this. Here's an example of a Lexell stereotactic radiosurgery series for 125 convexity cranial meningiomas in Kanzioka's study in neurosurgery 2009. 55 had prior surgery and 70 had no prior treatment. 76 were females and 49 males, again, predominant female groupings. Multiple cranial meningiomas were seen in this case, seen here and here on the left, and then in the suboccipital region, first on the left and then on the right. The location for these 129 meningiomas, predominantly in the parietal, temporal, occipital, and frontal regions. Again, left posterior frontal tumor seen on this T2 axial MR is seen here, and look at the marked edema with a resultant shift left to right. The mean tumor volume in primary control for these lesions, 7.6 mLs for these lesions was the mean tumor volume. I showed you previously a series where it was 7.5 mLs. Stereotactic primary control was achieved in 92% of tumors. And here's an example of a left posterior frontotemporal convexity, a meningioma that may have been readily controlled with such stereotactic radiosurgery. The control rate and morbidity for grade 1 lesions with no prior surgery, the control rate at 3 years was 95.3%, at 5 years was 85.8%. Morbidity was 9.6%, with 5% showing findings an average of 8 months postoperatively. And here's an example of a right posterior frontal convexity meningioma that may well have been treated with stereotactic radiosurgery. Single fraction stereotactic surgery was used for 416 meningiomas in Pollack series in neurosurgery in 2012. There were 416 WHO grade tumors. 337 were located at the cranial base or the tentorial regions. And here's just an example of a cranial base meningioma, predominantly involving the sella and suprasellar regions. The plan for single fraction treatment for these 416 tumors was to look at these 416 patients, benign lesions followed over a 60-month duration, so essentially nearly a 5-year period. And here you can see to the right an example of a foramen magnum meningioma with some distal involvement of the clivus as well. The average tumor volume and complications seen in this Pollack series of single fraction stereotactic radiosurgery for 416 meningiomas in 2012. Average tumor volume here was 7.3 cms. We've already seen 7.5 and 7.6. Median margin dose was 16 gray. The complications seen in 45 or 11% of the patients involved permanent neurological deficits occurring an average of 9 months following treatment. And here's an example of a right skull base meningioma with a treatment plan superimposed. Complications in Pollack series 2012 at 1 year, 6%, at 5 years, 11%, and more complications, as anticipated, were seen for the parasagittal and falcine lesions, and here shown on the right of the slide is a left parasagittal meningioma extending densely into the falx and the suprasagittal sinus. Disease-free survival out of these 416 patients, 5 years was 97%, 10 years was 94%. Tumor control parallel these numbers, 5 years 96%, 10 years 89%. And here is just an example of a stereotactic plan for treating a parasagittal meningioma. Paracerial meningioma, rather. Long-term control for 4,565 benign cranial meningiomas treated with Gamma knife stereotactic radiosurgery in Santa Croce series in neurosurgery in 2012. These data were accumulated from 15 centers. The average tumor volume was 4.8 cm, again well below the 7.3, 7.5, and 7.6 sizes seen in some of the other studies. These patients were followed at an average of 63 months, so just over 5 years. Here's an example of a right paracellular meningioma involving also the proximal clivus that may well have been included in this study. Post-stereotactic radiosurgery with the Gamma knife tumor volume, 4,565 treated tumors. Tumors decreased in 58% of cases, remained unchanged in 34.5% of cases, and increased in just 7.5% of cases. The control rate and survival rates for these over 4,500 treated meningiomas with Gamma knife stereotactic radiosurgery in 2012, the control rate was 92.5% at 5 years. Survival rate was 95.2% at 5 years and 88.6% at 10 years. Here's just an example of a right post-mortem view of a temporal meningioma. Morbidity and recurrence rate for these 4,500 meningiomas utilizing Gamma knife stereotactic radiosurgery in 2012, 6.6 rate of permanent morbidity and recurrence rate of 2.2%. That was 84 cases total. And again, this was seen in your larger lesions. And here's an example on your right of a large right-sided parasagittal meningioma. Let's switch then to looking at open surgery alternatives for cranial meningiomas. Here on the image that you're looking at of a T1 enhanced MR midline view, a frontal lobe or subfrontal lesion with extension into the pituitary fossa. Open surgery for 163 convexity meningiomas was recounted by Marikoff in neurosurgery in 2008. The series followed patients from 1985 to 2005, and the average follow-up was 2.3 years, ranging from 1 to 13 years in duration. And here's an example of a classical subfrontal meningioma on a T1 midline sagittal enhanced MR. The sex and average age for these patients, females 2.7 to 1 male, again, reflecting the female predominance throughout all of these series. The average age was 57 with a range of between 20 to 89 years of age. And here's an example of a left posterior frontal meningioma with actual extension into the skull that likely in this case required surgical resection. The pathology for the open surgery for these 163 convexity meningiomas evaluated by Marikoff in 2008, 155 were benign lesions, 16 were atypical tumors, and 3 were anaplastic lesions. If you look at the T1 enhanced MRI scan towards the right, here's a right frontotemporal skull base meningioma that could well have been included in this series. The 5-year recurrence rate for these 163 convexity meningiomas after open surgery for benign lesions was 1.8%. For atypical lesions was 27.2%, and as would be anticipated, for the anaplastic lesions was a 50% incidence. So here on the MR to your right, this is a T1 enhanced MR. You're seeing a right suboccipital lesion, a new left occipital lesion, and sagittal-parasagittal right-sided lesion plus temporal meningioma seen far to the right. Postoperative deficits, complications, and mortality rates for open surgery for 163 convexity meningiomas in Marikoff series in 2008. New postoperative deficits in 1.7%, an overall complication rate of 9.4%, and 0% 30-day mortality. And here's another example of a parasagittal meningioma, here not extending all the way into the superior sagittal sinus. Recurrent surgery required for 100 subpial versus extrapial convexity meningiomas in Alvernia series from JNS 2011. Let's just start with the symptoms for these patients. Headache, 67%, seizures, 40%, visual loss, 39%. And here's just another example of a large convexity meningioma seen on a sagittal T1 enhanced MR. The pathology and recurrence rate for these 100 convexity meningiomas from Alvernia series, 95 patients were grade 1 WHO, and 5 were atypical grade 2 tumors. At 7.2 years, 4 tumors recurred. 2 were from the grade 1 and 2 from the grade 2 categories. And here's an example of a left occipital recurrent meningioma as well as new lesions seen as well. So here is your left recurrent lesion seen here, some pouting through the previous operative defect, and incidental new daughter lesions in the left temporal region and the right temporal regions. There was a lower recurrence rate seen for extrapial meningiomas, WHO grade 1 tumors. It was 1.2% recurrence rate for extrapial lesions as opposed to a higher recurrence rate for subpial lesions. And here is an enhanced T1 MRI of a subpial left posterior frontotemporal meningioma with a lesion recurring as shown. In Mazou's study, Management of 74 Symptomatic Cranial Meningiomas, published in 2012 in Surgical Neurology International, the symptoms in this series paralleled those in the previous series. 67% incidence of headaches, 40% frequency of seizures, and 38% visual loss. For a left subfrontal temporal meningioma, seen here on a T1 enhanced MR on a coronal image, on a sagittal image, and on an axial study, these are the typical types of tumors that would be in this kind of series. The tumor locations, the convexity, parasagittal and falx regions, sphenoid wing, olfactory groove, and here is a bifrontal subfrontal skull-based meninge seen on a T1 enhanced study, bilaterally subfrontal on the coronal image, and seen on the midline sagittal lesion in image as well. More tumor locations for the series: the tentorium, the posterior fossa, and the sella, and here's a massive suprasellar meningioma that may well have been included in that study. What was the surgical pathology for 42 of these patients undergoing surgery? That was 56.8% of the total group where histology was available. 39 were WHO grade 1 lesions, 1 was an atypical grade 2 tumor, and 2 were anaplastic lesions. And here you can see a left-sided occipital falcine meningioma with edema and shift. The blue arrow is showing you the left suboccipital lesion coming off of the falx, and here the green arrow on these two images is showing you the edema and marked compression of the ventricle. Total surgical resection was achieved in 41 of 42 operated meningioma in this series. There was 1 surgical mortality. And here's an example of a massive subfrontal skull base meningioma seen here on a T1 enhanced study. This one before and that following resection. Surgery for 665 cranial meningiomas in Ramey's series from Medical Archives 2018. Again, female predominance here was 2.4 females to 1 male, pretty much within the range that we've been seeing. The average age here was slightly younger at 49.6 years of age, and they were followed 8.7 years in duration. Here's an example of a left interventricular meningioma, massive tumor seen here with the red arrow, and the green arrow is showing you the massive shift, and it's blocking the outflow of the ventricular system. The location for these 665 cranial meningiomas: parasagittal, convexity, tentorial, and interventricular. Those were the majority of cases. Here's your left interventricular meningioma seen on a classical T1 enhanced axial MR image. Resection for these 665 meningiomas: gross total resection 73.1%, subtotal removals in about 26.9%. And here's an example of a left posterior falcine meningioma status post resection. So here's the pre-op and here's the post-op image. Postoperative neurological deficits: 64 had persistent deficits, 16 had new deficits. Those with larger lesions, defined as over 4.5 cms, had a 28% incidence of residual and or new deficits. And here's an example of a distal clivus foramen magnum meningioma, pre and post-op. Recurrent lesions and deaths for these 665 cranial meningiomas in Ramey series: 95 cases, or 14.2% of 665 tumors recurred. Post-operative deaths, by the way, were seen. 1 was immediate and 42 were delayed. Epidemiology of meningiomas in Champeau series in Cancer and Epidemiology 2019. So this is a very recent study. Over 25,000 surgical meningiomas seen. Most were between the ages of 60 to 64, with the average ages for the females being 59, for the males being 57. This is an example of a bilateral subfrontal skull base meningioma that may well have been included in the series. Pathology for these 25,000 meningiomas: benign lesions 91%, atypical lesions 6.2%, and malignant lesions in 2.5% of cases. So here's an example of a left temporal meningioma seen on post-mortem pathological specimen. The frequency of meningiomas: 4.5 per 100,000 per year in Champeau's study 2019. Most involve the convexity or the middle skull base, and here's a meningioma filling the right frontal temporal skull base. There are indeed many options for managing asymptomatic and symptomatic meningiomas. For the asymptomatic patients, non-surgical options can be utilized. We showed you a series of 57 patients back from Oliva's study in 1995, where they were treated for several years' duration without evidence of sufficient growth to warrant new surgical intervention. For patients who have symptomatic lesions, on the other hand, some may require stereotactic radiosurgery, CyberKnife, Gamma Knife, any other device. Alternatively, those patients who are severely symptomatic with severe edema, and massive shift that are threatening herniation, open surgery may certainly still be warranted. You need to determine what is required to manage your patient's individual cranial meningioma. Is it no surgery if they're symptomatic? Is it stereotactic radiosurgery? Is it open surgery? You need to tailor the treatment to your patient's individual needs, and I'd like to thank you.